In this video, the anterolateral abdominal wall and the inguinal region will be discussed. To begin, I would like to orient you to the surface anatomy of the abdominal wall. The abdominal wall is a dynamic structure that contracts to increase intra-abdominal pressure and distends to accommodate expansion for pregnancy, ingestion, fat deposition, and even pathology. To describe the location of abdominal organs, pain, or pathology, two different systems can be used. The first and more complex system is the 9-region system. To establish this tic-tac-toe board-shaped system, two vertical planes are laid out from the midclavicular lines down to the mid-inguinal points. These circles here represent the mid-inguinal points, and here are the two midclavicular planes passing through the midclavicular points. Next, two horizontal planes are established. The first is referred to as the subcostal plane, shown here, which is positioned just inferior to the costal margin. And the second horizontal plane is the intertubercular plane, shown here to the left and right. The intertubercular plane crosses through the iliac tubercles, which are indicated here in red and circled in green. Notice that these iliac tubercles are positioned just superior to an important structure called the ASIS, which stands for the anterior superior iliac spine. These four planes produce 9 different regions. There are 2 hypochondriac regions. As their name suggests, they are positioned just below the costal margin. The word hypo means below, and the word chondriac refers to cartilage. Situated between the left and right hypochondriac regions is the epigastric region. Just below the epigastric region is the umbilical region, where the umbilicus is positioned. And just below the umbilical region is the hypogastric region. Flanking either side of the hypogastric region is the left and right iliac region. And as you may notice between these two images, there is different terminology that might be used. For example, some may refer to the hypogastric region as the pubic region. Technically speaking, the term hypogastric is more accurate. Lastly, there are 2 lumbar regions, a left and a right, which flank the umbilical. Let me also mention that some individuals will use the transpyloric plane in order to establish the 9-region system. This plane, shown here by the red hash-dotted line, represents the midway point between the jugular notch, here at the top of the manubrium, and the pubic symphysis, shown here adjoining the 2 pubic bones. This plane tends to be a little more useful than the subcostal plane because of all of the various abdominal structures associated with this plane of section. Let's take a closer look. The transpyloric plane passes through the body of the L1 vertebra, not shown here in this image. It also passes through the pylorus of the stomach, which is this region here. It passes through the first part of the duodenum, shown here. Passes through the fundus of the gallbladder, which I'll temporarily draw in here. It also passes through the pancreas, as well as the hyla of the kidneys. You can see in relief here the hyla of both kidneys, through which the transpyloric plane passes. Another key structure that we'll talk about at length is the superior mesenteric artery, shown here with the X. Notice that this artery slides behind part of the neck of the pancreas to originate from the aorta. And so the transpyloric plane essentially crosses through the origin of the superior mesenteric artery as well. In the abdomen, the transpyloric plane is just as important as the transverse thoracic plane was in the thorax. The more commonly used system is the 4-quadrant system, which divides the abdomen into a right and left upper quadrant, as well as a right and left lower quadrant. The median plane, shown here, along with the transumbilical plane, which cuts through the level of the umbilicus, are used to establish this 4-quadrant system. From a clinical reasoning perspective, it will serve you well to know which major organs are located in each region. For now, simply appreciate that as clinical cases arise, you will likely be asked to think about locations of internal organs in relationship to either the 9 or 4-quadrant system. This becomes especially important when trying to describe and localize abdominal pain. Two of the most common general surgery procedures that are performed are cholecystectomies, which is a removal of the gallbladder, and appendectomies, removal of the appendix. As such, I would like to highlight some surface landmarks to help identify where these particular structures are located. The fundus of the gallbladder can be found where the transpyloric plane crosses the right costal margin. And from the previous image, recall that the transpyloric plane is the midway plane between the jugular notch above and the pubic symphysis below. If a patient is suspected to have inflammation of the gallbladder, the physician is likely to palpate the region here at the midpoint of the costal margin in order to elicit abdominal pain. The appendix is a worm-like projection that extends from the cecum, which is the first part of the large intestine. Open incisions for appendectomies are made at McBurney's point, shown here. In order to locate this point, the ASIS is palpated, which again stands for the anterior superior iliac spine, and the umbilicus is located. 1/3 the distance between the ASIS and the umbilicus represents McBurney's point, indicated here by the star. Now that you have had some general exposure to surface anatomy, let's begin to peel back the layers of the anterolateral abdominal wall. The superficial abdominal wall is composed of skin, subcutaneous fat, and membranous fascia. The fatty layer of superficial fascia, called Camper's fascia, which is shown here in yellow, is continuous with the fat of the perineum. The perineum is simply the area between your thighs. Camper's fascia contains within it cutaneous nerves and a subcutaneous venous plexus. If you think of a camper trying to stay warm on a cold night in the wilderness, it will help you to remember that Camper's fascia is the fatty outer layer for warmth. The deep membranous layer of superficial fascia is shown here in blue and is known as Scarpa's fascia. Here in the perineal region, Scarpa's fascia is continuous with Colles' fascia, and at the crease of the thigh, shown here, Scarpa's fascia is continuous with the fascia lata of the thigh, shown in mint green. When suturing the lower abdominal wall, surgeons might include Scarpa's fascia to provide added strength for suturing the stitch and securing the stitch to the wall. And between Scarpa's fascia and the underlying flank muscles is a translucent membrane of investing fascia, which covers the muscles themselves. Overtop the rectus abdominis muscle, Scarpa's fascia is superficial to the anterior rectus sheath, which we'll discuss more at length in a moment. Also recognize that Scarpa's fascia is more prominent in the lower reaches of the abdomen. Along the anterolateral abdominal wall, the first muscle deep to Scarpa's fascia is the external oblique muscle, the largest and most superficial of the 3 flank muscles. Superiorly, the external oblique muscle makes its attachment onto the external surfaces of the lower 8 ribs. And inferiorly, the muscle inserts onto the pubic tubercle as well as part of the iliac crest. In the midline, the external oblique aponeuroses decussate at an area called the linea alba, which, when literally translated, means white line. Notice the direction of these muscle fibers. This will be one way in which you identify this muscle in lab. Suppose you were wearing a hoodie, and suppose you stuck your hands into the pocket of that hoodie. The direction of your fingers would represent the orientation of the external oblique muscle fibers. The external oblique muscle is innervated by the thoracoabdominal nerves as well as the subcostal nerve. And in the inguinal region, which is the region here, the external oblique aponeurosis folds onto itself to form what is called the inguinal ligament. We'll talk more in depth about this ligament in a moment. The muscle fibers of the internal oblique are oriented more or less perpendicular to those of the external oblique. Posteriorly, the tendon of the internal oblique muscle is an extension of the thoracolumbar fascia, which is derived from the investing layer of fascia surrounding both the quadratus lumborum muscle and surrounding the erector spinae muscles, indicated here as the deep back muscles. Like the external oblique, the tendinous aponeuroses of the internal oblique also decussate in the midline at the linea alba. Superiorly, the internal oblique muscle attaches to the lower border of the lower three ribs, and it attaches inferiorly to both the pecten pubis as well as the conjoint tendon. We'll see better examples of these structures later on. Working in concert with one another, both the external oblique and the internal oblique will help to compress abdominal viscera as well as flex and rotate the trunk. And all the trunk muscles are innervated by the thoracoabdominal nerves. The transversus abdominis muscle is the deepest of the three flank muscles, and its fibers run transversely across the abdomen. This muscle is important for compressing abdominal contents and increasing intra-abdominal pressure, for defecation, for example. The transversus abdominis is also derived from the thoracolumbar fascia. That is, the posterior tendon of the transversus abdominis is derived from the thoracolumbar fascia. Other areas of this muscle will originate from the iliac crest and the costal margin. And once again, the fibers from the aponeurosis will decussate in the midline at the linea alba. The vertically oriented muscle on the anterior abdominal wall is the rectus abdominis muscle, which spans from the costal cartilages of ribs 5 through 7 to the pubic symphysis and the pubic crest. And just like the flank muscles, the rectus abdominis is also innervated by the thoracoabdominal nerves. Again, the linea alba is the midline separation between these paired rectus abdominis muscles. Again, it is the area of decussation where the aponeurotic tendons of the flank muscles cross. There is also an area to the sides of both rectus abdominis muscles referred to as the linea semilunaris, demonstrated here by the green line. The linea semilunaris marks the point of transition between the rectus sheath and the aponeuroses of the flank muscles. It is a line of fusion along the lateral border of the rectus abdominis muscles. On occasion, the rectus abdominis muscles can separate as a consequence of excessive intra-abdominal pressure. This muscle separation and stretching of the linea alba is referred to as rectus diastasis. Women are especially at risk for abdominal muscle separation during pregnancy, as the increased pressure of the growing fetus expands the uterus, thereby pressing against the anterior abdominal wall. And the second population at greatest risk would be newborns. Lastly, sometimes a small triangular-shaped muscle called the pyramidalis muscle can be found in about 20% of the population. This small muscle attaches to the pubis and the linea alba. Down here would represent the area of the pubis, and here again is the midline linea alba. This inconsequential muscle is said to tense the linea alba. The erectus sheath is made of flat tendon-like aponeuroses from the three flank muscles, and it surrounds the upper rectus abdominis muscles. Here's an example of the posterior rectus sheath. Again, there are two lines of fusion where these aponeuroses meet. The first is this linea semilunaris, situated at the lateral edge of the rectus abdominis muscles, shown here. And then the midline decussation again represents the linea alba. From this cross-sectional perspective, this area here would represent the linea semilunaris, whereas the linea alba would be represented by this midline decussation. Before we go any further, I want to introduce the concept of the arcuate line. The arcuate line is the transition point at which the lower rectus abdominis muscle comes into direct contact with the transversalis fascia. The arcuate line tends to occur about 2/3 the distance between the pubic symphysis and the umbilicus. So here's the umbilicus, here's the pubic symphysis, and so again about 2/3 the distance between those two structures is the arcuate line. The transversalis fascia, which is shown here in mint green, is a fascial plane that separates the muscles of the abdominal wall from the parietal peritoneum, which lines the abdominal cavity. Within the extraperitoneal space between the transversalis fascia, shown here, and the peritoneum, shown here, lives a layer of fat. We'll call this layer the extraperitoneal fat. While you will be able to appreciate the transversalis fascia in your cadavers, it will likely be very difficult to appreciate the extraperitoneal fat layer. Said in a different way, the arcuate line is the transition point at which there is no longer a posterior rectus sheath behind the rectus abdominis muscle. This area here represents the posterior rectus sheath. All of this white here over top of the right rectus abdominis muscle is representative of the anterior rectus sheath. And you notice here that at the arcuate line, that posterior rectus sheath stops, and all you see is transversalis fascia. Figure A below represents a cross-section above the arcuate line. And figure B represents a cross-section below the arcuate line. Above the arcuate line, the aponeuroses of 1½ muscles form the anterior rectus sheath. Specifically, the aponeuroses of the external oblique muscle, in addition to half of the aponeurosis from the internal oblique muscle, will comprise the anterior rectus sheath, shown here. In a similar way, the posterior rectus sheath above the level of the arcuate line is also made up of tendons and aponeuroses from 1½ muscles. We have the tendon of the transversus abdominis muscle, as well as half of the aponeurosis from the internal oblique muscle. Again, both of those together form the posterior rectus sheath. In contrast, below the arcuate line, all three aponeuroses from the external oblique, the internal oblique, and the transversus abdominis muscles contribute only to the anterior rectus sheath, shown here. There is no posterior rectus sheath below the arcuate line. Instead, there is only transversalis fascia indicated by the green structure. And of course, just deep to that layer of transversalis fascia would be a very thin extraperitoneal fat layer, followed by the parietal peritoneum, which again is the lining of the abdominal cavity. As you may recall from the thorax presentations, the intercostal nerves of T7 through T11 change names to become the thoracoabdominal nerves as they cross the costal margin, shown here. Here are the intercostal nerves within the intercostal spaces, and as soon as they cross the margin, they change names to become the thoracoabdominal nerves. Just as the intercostal nerves were found between the internal and innermost intercostal muscles, the thoracoabdominal nerves are found in the same intermuscular plane between the internal oblique and the transversus abdominis muscles. Do recognize that these thoracoabdominal nerves and intercostal nerves contain general somatic afferent fibers in their cutaneous branches. These fibers carry sensory information from the skin. Notice the dermatomal distribution of the abdomen. It involves nerves T6 through T12. The key point to remember is that the umbilicus lies at the level of the T10 dermatome, as shown here. If you can remember this landmark, you'll be able to logically discern the other dermatomal levels by walking either up or down from the level of the umbilicus by about 2 finger breaths at a time. The primary arteries that supply the anterolateral abdominal wall include the following: the superior epigastric artery and the musculophrenic arteries. You might recall from the thorax lecture that the internal thoracic artery, shown here, divides and terminates as the musculophrenic artery, which follows along the margin of the costal margin, and it also terminates as the superior epigastric artery, which runs just behind and deep to the rectus abdominis muscle. Another important artery supplying the anterior abdominal wall would be the inferior epigastric artery. This artery arises from the external iliac artery, and it will course behind the rectus abdominis muscle as well to supply that muscle along with the superior epigastric artery. Notice how the posterior intercostal arteries are wrapping around from the back toward the front, as shown here. And there's also a subcostal artery as well. Recall that the posterior intercostal arteries arise directly from the descending thoracic aorta. In addition, there will also be lumbar arteries that will help to supply the posterior abdominal wall. Unfortunately, those arteries are not visible in this image. We'll see those arteries in a later presentation. And as usual, you can expect to find veins of the same name that parallel these arteries. The additional veins pointed out here on the right-hand image also drain the abdominal wall. Specifically, they drain the superficial fascia. The periumbilical veins, shown here surrounding the umbilicus, are subcutaneous veins, and they're going to communicate with paraumbilical veins, which will course through the round ligament of the liver. We'll discuss that more in a moment as well. Also notice the thoracoepigastric vein communicates with the periumbilical veins, and it will drain back to the axillary vein. The thoracoepigastric vein is often in the way for breast surgeons when they are performing axillary dissections. In a condition called portal hypertension, the paraumbilical veins, which course internally with the round ligament of the liver, and their tributaries within Camper's fascia, called the periumbilical veins, can dilate, thereby opening a connection between the portal and cable system, referred to as the portal cable anastomosis. This anastomosis allows portal blood from the GI tract to be shunted to the cable system in order to be returned to the heart. When the periumbilical veins become engorged with blood and radiate outward from the umbilicus, they resemble Medusa, the monster from Greek mythology with a head full of snakes instead of hair. As such, this sign for portal hypertension has become referred to as caput medusa. When it comes to understanding the lymphatics of the abdominal wall, simply recognize that lymphatic vessels above the level of the transumbilical plane, shown here, drain to the axillary and peristernal lymph nodes. The peristernal lymph nodes flank the sternum on either side, and the axillary nodes are found in the axilla. Lymphatics below the transumbilical plane will drain to superficial inguinal lymph nodes, shown here along the inguinal ligament. For the sake of completeness, this image demonstrates structures along the internal surface of the anterior abdominal wall, which are associated with peritoneal folds and reflections. The falciform ligament, shown here, is a remnant of the embryonic ventral mesentery. It is found above the umbilicus, and it runs in the midline along the internal surface of the anterior wall. The falciform ligament helps to secure the liver to the anterior wall, and it has a sickle-shaped appearance to it, even though that appearance cannot be appreciated from this cross-sectional view. Below the umbilicus are the median, medial, and lateral umbilical folds that contain the obliterated urachus, the obliterated umbilical artery, and the inferior epigastric vessels, respectively. Here is a better view of these structures. Notice again the falciform ligament. It is sickle-shaped running from the liver to the anterior abdominal wall. At the lower free margin of the falciform ligament is the round ligament of the liver, and running within it are the paraumbilical veins that drain the subcutaneous venous plexus. Also seen from this perspective is the median umbilical fold, which is peritoneum overlying the urachus. The urachus is a remnant of the embryonic allantois. In the fetus, the allantois was a canal connecting the fetal urinary bladder to the umbilicus for drainage of urine. Immediately lateral to the median fold is the medial fold. Again, this fold contains the remnant of the umbilical artery. And lastly, the lateral umbilical folds on both sides will contain the inferior epigastric vessels, as shown here. Notice that we can also appreciate the arcuate line from this perspective. Again, that is the terminal end of the posterior rectus sheath, shown here above. This is why we're only seeing muscle fibers here and not seeing any of the rectus sheath, because below the arcuate line, we only have transversalis fascia, which has been opened up. The remainder of this presentation will focus on structures of the inguinal region. The inguinal ligament, shown here, spans from the anterior superior iliac spine down to the pubic tubercle, which is a small bump of the pubic bone. The inguinal ligament is formed by the external oblique aponeurosis, as that aponeurosis folds onto itself. Running along the pectineal line of the pubis, which is shown here, is the pectineal ligament, also known as the ligament of Cooper or just Cooper's ligament. Cooper's ligament is a thickening of periosteum along the pecten pubis. During a McVeigh procedure, for example, which is a procedure to repair a hernia, sutures can be placed here in Cooper's ligament and secured in this region. The lacunar ligament, shown here, spans between the pectineal ligament and the inguinal ligament, and it forms a shelf on which the spermatic cord will rest. In the lower left image, I simply wanted to highlight what the pubic tubercles look like. And here is the spermatic cord coming through the inguinal canal. The inguinal canal is about 4 centimeters long, a little less than 2 inches, and it spans between the internal or deep inguinal ring, shown here, and the external, also called the superficial inguinal ring, shown here. This canal is the route by which the male testes and their contents of the spermatic cord will pass from the abdominal cavity into the scrotum. There are 4 main boundaries associated with the inguinal canal. The posteriormost boundary, represented here in red, is the transversalis fascia. The anterior wall of the inguinal canal, shown here in yellow, is the aponeurosis of the external oblique muscle. The floor along the middle third of the inguinal canal is made up of the inguinal ligament, shown here in blue. And finally, the roof of the middle third of the inguinal canal is made up of a musculoaponeurotic arch that comes from both the internal oblique muscle and the transversus abdominis muscle, shown here in green. The 2 main contents passing through the inguinal canal are the spermatic cord, or the round ligament of the uterus in the female, and the ilioinguinal nerve. The inguinal canal begins at the deep inguinal ring, also known as the internal inguinal ring, which is indicated by the red oval. The inguinal canal will end at the superficial or external inguinal ring. Note that the superficial inguinal ring is formed by a split in the external oblique aponeurosis. All this white here demonstrates the external oblique aponeurosis. The lateral crus, which is the leg of the ring, attaches to the pubic tubercle, again shown here, which is a small bump on the anterior pubic bone. The medial crus attaches to the pubic crest, which lies just medial to the pubic tubercle. Here's the medial crus of the superficial inguinal ring. In addition, there are also intercrural fibers that arc between the medial and lateral crura. Here are those fibers, the intercrural fibers. These fibers prevent the roof of the inguinal canal from splitting open like a banana. During dissection, you'll be on the lookout for the medial and lateral crura, which define the opening of the superficial inguinal ring. Here is another view of the roof and the posterior wall of the inguinal canal. Notice how the fibers of the transversus abdominis muscle arch over top of the spermatic cord near the deep inguinal ring. This arch acts like a shutter on a camera. As intra-abdominal pressure increases, this musculoaponeurotic arch clamps down to reinforce this otherwise weak area, and it prevents small bowel from entering into the deep inguinal ring, thereby causing a herniation. And let me also point out that the deep inguinal ring, shown here, is immediately lateral to the inferior epigastric vessels. The location of the deep inguinal ring relative to these vessels has relevance when considering inguinal hernias. Located medially and deep to the area of the superficial inguinal ring is the conjoint tendon, in this area here. The conjoint tendon is also known as the inguinal falx or the falx inguinalis. The conjoint tendon is a shared aponeurosis between the internal oblique and the transversus abdominis muscles. During a hernia repair, both the rectus abdominis muscle and the conjoint tendon can be used as anchor points for sutures. There are multiple types of hernias, the most common of which are inguinal hernias. A range of 750 to 900,000 inguinal hernias are performed annually within the United States. Umbilical hernias are ranked as the second most common type, and the least common are femoral hernias, shown here. Femoral hernias are those that protrude just below the inguinal ligament. For context, here's the anterior superior iliac spine, abbreviated ASIS, and so this would be the location of the inguinal ligament. In general, inguinal hernias are more common in men, they tend to occur on the right side, and they tend to be indirect. Though they are rare, femoral hernias are more common in older female patients and in patients who have previously undergone hernia repair. Femoral hernias are those that again herniate from beneath the inguinal ligament. Direct versus indirect inguinal hernias are named according to their position within or outside of Hasselbalch's triangle. Hasselbalch's triangle has three borders. The medial border is made up of the lateral edge of the rectus abdominis muscle. The floor of the triangle is represented by the inguinal ligament, the distal portion of the inguinal ligament, that is. And the lateral border of this triangle is formed by the inferior epigastric vessels. A hernia that protrudes through the triangle, in other words, medial to the inferior epigastric vessels, is said to be a direct inguinal hernia. A hernia that occurs just lateral to the inferior epigastric vessels and is therefore outside of the triangle is said to be an indirect inguinal hernia. Indirect inguinal hernias often protrude through the deep inguinal ring and enter into the inguinal canal. Palpation of a hernia at the superficial inguinal ring is performed with the examiner's finger following the spermatic cord to the superficial ring. If a hernia is present, a sudden impulse is felt against the fingertip when the physician asks the patient to cough or bear down. Now, sometimes a noticeable bulge in the area of the superficial inguinal ring is also present. However, the palpation of that bulge alone is not discriminatory enough to discern whether it would be a direct or indirect inguinal hernia, because a bulge can exist at the superficial ring in either case. If a mass were to be detected near the deep inguinal ring, and an impulse was also felt at the superficial inguinal ring, then that would suggest an indirect inguinal hernia. In general, it can be a real challenge to differentiate between direct and indirect inguinal hernias upon physical examination. Oftentimes, the type of hernia is classified upon surgical repair. The skin in the lower abdomen and the inguinal region is innervated by two nerves, both of which originate from the L1 spinal nerve. The iliohypogastric nerve, shown here, pierces through the external oblique muscle to innervate the skin of the lower abdomen just above the pubis, in this area here. The ilioinguinal nerve, which is shown adjacent to it, provides cutaneous innervation to the skin over the pubis, and it also innervates the anterior scrotum in males, or the mons pubis and labia majora in females. There's also a small portion of this nerve which will innervate a small area along the upper medial thigh. During dissection, when you open the external oblique aponeurosis, as it's shown here, you'll find the ilioinguinal nerve courses just lateral to the spermatic cord. Here's the ilioinguinal nerve on the lateral aspect of the spermatic cord. Now in females, there is no spermatic cord. In its place, there is the round ligament of the uterus. Local anesthetic can be injected superomedial to the anterior iliac spine, again, which is here. By injecting anesthetic in this region, you can block the ilioinguinal and iliohypogastric nerves in advance of inguinal hernia repair. One of the first steps in repairing a hernia for surgeons is to identify and isolate the ilioinguinal nerve. If this nerve is compromised, in males, they might experience a paresthesia or a numbness of the anterior scrotum and the anterior pubic area. Recognize that the ovaries and the testes develop along the posterior abdominal wall. In males, the testes must eventually migrate to their final destination of the scrotum. To accomplish that requires assistance from the gubernaculum, which is a fibrous cord, a guy wire if you will. This guy wire connects each primordial testis to the future deep inguinal ring. Here's the gubernaculum, and here's the remnant of the gubernaculum called the scrotal ligament in the adult form. While the gubernaculum helps to guide the testis along its descent, at the same time, there's another structure called the processus vaginalis, which is an outpocketing of the parietal peritoneum that will extend alongside the gubernaculum, and it will traverse the developing inguinal canal to enter into the primordial scrotum. As you see here, it forms a pocket into the scrotum. By week 32, the testes have entered the scrotum. The connection with the abdominal cavity is then obliterated, leaving behind a peritoneum-lined space just anterior to the testis. This space is referred to as the tunica vaginalis, as shown here. We say that the tunica vaginalis is the remnant of the processus vaginalis. There may be instances in which the processus vaginalis fails to obliterate. When this occurs, an individual is at higher risk for something called a hydrocele, and also at higher risk for hernia. A hydrocele is simply an accumulation of fluid within the tunica vaginalis surrounding the testis, or it could occur along the length of the spermatic cord from failure of the processus vaginalis to close and obliterate. Here is an example of a non-communicating hydrocele, because the fluid is localized to the area of the tunica vaginalis only. This communicating hydrocele indicates that the processus vaginalis did not obliterate at all, and in fact there is an open connection between the abdominal cavity and the tunica vaginalis. And the third option would be to have a cyst form somewhere along the length of the remnant of the processus vaginalis. Here is an image of all three fascial layers of the spermatic cord. The external spermatic fascia comes from the external oblique aponeurosis shown here in green. Notice how this aponeurosis extends onto the spermatic cord as the external spermatic fascia. The cremasteric fascia comes from the internal oblique muscle shown here in orange. Here it is extending onto the spermatic cord as the middle layer of cremasteric fascia. And thirdly, the internal spermatic fascia, shown here in this cream color, is derived from the transversalis fascia. Notice how the transversus abdominis muscle, shown here in light blue, has no contribution to the fascial layers of the spermatic cord. The cremaster muscle is contained within the cremasteric fascia. This muscle will draw the testes superiorly in response to cold, for example. Or, if it's a warm day, this muscle will relax and allow the testes to descend. Overall, the cremaster muscle is very important to help regulate the temperature of the testes for spermatogenesis. Repair of inguinal hernias may require dissection of the spermatic cord, so it can be useful to understand what this cord contains. First and foremost, it contains the vas deferens, also known as the ductus deferens. Here's that structure in cross-section, and here's the vas deferens from another angle. This is a muscular tube which conveys sperm from the epididymis to the ejaculatory ducts. Adjacent to the vas deferens is a tiny squiggly artery called the artery of the vas. Also in the spermatic cord is the pampiniform plexus of veins, as shown here. These veins converge to form the single testicular vein, which will empty into the left renal vein or empty directly into the inferior vena cava. And usually found in the middle of the pampiniform plexus of veins is the testicular artery, shown here, and the testicular artery is shown here. This artery arises directly from the abdominal aorta, and it supplies the testis. It also supplies the epididymis. These next structures that are grayed out are really small, so I doubt that you'll be able to find these in lab, but nonetheless, they are contained within the spermatic cord. These structures include the cremasteric artery and the autonomics to the region, so there are sympathetics going down to the spermatic cord and coursing within the cord itself for the vasculature. Autonomics are not only needed for the vessels, but also needed for the vas deferens. These autonomics are generally referred to as the testicular nerve plexus. There is also a genital branch of the genital femoral nerve, which is innervating the cremaster muscle. And lastly, there are very tiny lymphatic vessels that help to drain the region of the testis. As a clinical correlate, I thought I would introduce testicular torsion. Testicular torsion is a twisting of the spermatic cord that causes testicular ischemia because the arterial supply and the venous drainage are obstructed by the twisting. While testicular torsion can occur at any age, it is most common during adolescence and typically occurs above the superior pole of the testis as shown here. Corrective surgery may be needed to untorse the testis. And lastly, I would like to describe the contents of the female inguinal canal. Just like we saw in males, females also have an ilioinguinal nerve. This nerve courses along the lateral aspect of the inguinal canal, sliding along the round ligament of the uterus, which is shown here. The round ligament of the uterus is going to insert onto the mons pubis. That ilioinguinal nerve is therefore going to provide cutaneous innervation to the skin of the mons pubis, and it will also supply cutaneous innervation to the anterior labia majora. Recognize that the labia majora are the homologue of the scrotum in males. Also in females, accompanying the round ligament of the uterus is a very small artery called the artery of the round ligament. This can be useful for helping to differentiate between the ligament and the ilioinguinal nerve during dissection. This concludes the lecture on the anterolateral abdominal wall and the inguinal region. Thanks for listening.